Good evening and a warm welcome to all our followers on social media. Thank you for joining us today as we take you on another road of awareness and enlightenment. On the occasion of World Pulmonary Hypertension Day, which is May 5th of 2023, we aim to raise awareness about this frequently misdiagnosed disease. Today, Times of India, in association with MSN Laboratories, would like to bring about a special webinar on PAH awareness, and this is what we would like to call our education initiative. Not only are we aiming to increase awareness, we would also like to salute all the people who are suffering from PAH and also who are learning how to cope to live with it. In order to understand more about this particular ailment, let's hear from our panel of experts. I'd like to welcome Dr. Vikas Kohli, Diplomate, American Board, Pediatric Cardiology, Fetal, Neonatal and Pediatric Cardiologist, Delhi Child Heart Center, and Indraprastha Apollo Hospital. Dr. Vikas, welcome.
Thank you. Pleasure to be here.
Dr. Arun Chaudhary Kotaru, who's a consultant, respiratory medicine at Artemis Hospital, Gurgaon. Dr. Harnish Singh Bhatia, consultant cardiologist and head of cardiology at the RLKC and Metro Heart Institute, New Delhi.
Thank you
Dr.
so much.
Nitin Agarwal, consultant interventional cardiologist at the Sri Balaji Action Medical Institute, New Delhi.
Thank you. Have a good evening.
And Dr. Ashish Singhal, who's also here, DM cardiologist, Yamuna Vihar, Delhi. I think Dr. Ashish Singhal is not here, but we've got Dr. Ashutosh, who's just joined us. So let's give him a minute to turn on his video because we can start on the right note then with all the doctors in. All right. While we wait for Dr. Ashutosh to, yes, here he is. Dr. Ashutosh, a warm welcome. We have with us Dr. Ashutosh Marwa, Director, Pediatric and Adult Congenital Heart Disease from the Escort Hospital, New Delhi. While we wait for Dr. Ashish to settle down, I'd like to start with the first question to Dr. Vikas Kohli. Dr. Vikas, can you help us understand what exactly is pulmonary arterial hypertension?
We all are aware that hypertension is basically high blood pressure. And when that is referred to in the ordinary sense, it's the blood pressure we measure from the cuff in our arm. But pulmonary hypertension specifically refers to the high blood pressure in our lungs. Lungs is the only organ in the body from our head to toe where the pressures are around 25 or 30 maximum. And that is why gas exchange can happen. When these pressures rise beyond a certain limit, because of either lung disease, heart disease, or any other systemic disease, we call it pulmonary hypertension. And today's day in the world all over is focused on and dedicated to the patients who suffer from this particular condition, which is very different from systemic hypertension.
Thank you, Dr. Vikas. And I'm glad you're giving it to us in little bits because we probably will be able to comprehend it better. Dr. Ashutosh, welcome to the webinar. I totally understand that you must have been busy. Thank you so much for joining, and I'm going to put you right out into the lion's den by asking you the next question, which is, how common is pulmonary arterial hypertension? And could you also help us understand who is at risk for PAH?
Pulmonary artery hypertension is not very common, but at the same time, people are not aware that they have the disease. Just let me close this door. There's a lot of noise.
So, Dr. Vikas, could you tell me, is it called PAH or PH?
So patients are not aware, that they have this disease. So if one is aware, if one is feeling, excessively fatigued or tired, or patients who have, especially women, are more prone to get these diseases. So patients who suffer from connective tissue disorders such as arthritis or, SLE, they are also prone to have this disease. Then, especially more so in our circumstances, people who have uncorrected congenital heart diseases, they are also prone to get pulmonary artery hypertension. So it's a wide variety of causes that can lead to elevation of pressures in the pulmonary circuit.
Okay. Thank you, Dr. Ashutosh. Dr. Arun, could you tell us, is this, because we hear this all the time, is PH hereditary, or could there be some other specific reason why this happens?
Basically, the PH is divided into 5 groups. We classify the causes of PH as 5 groups. The first group is the hereditary group, where you have familial conditions where there is a gene which is responsible for transmitting this disease to the successive generation. And the first group also includes few conditions like connective tissue disorders and drug-induced pulmonary hypertension. And we do see other conditions which are rightly mentioned. You have your congenital heart diseases which are not corrected. There are some, the second group is due to the left heart. And the third group is which exclusively belongs to the lung, where you can see people who are extremely obese or who smoke or who have extreme asthma, they develop pulmonary arterial hypertension over a period of time. And there are some other conditions where miscellaneous conditions where you can see clots in the lung which are leading to pulmonary hypertension, as well as some rare conditions like blood disorders, amyloidosis, and some depositional diseases which are very rarely seen. That is categorized as group 5 in when you classify pulmonary arterial hypertension. Yes, genetic pulmonary hypertension is seen, but there are a wide range of causes.
Thank you, Dr. Arun. Dr. Harnish, I'm just going to continue on that note itself. When we are talking about these various aspects, is there any particular age group that seems to be, currently becoming more and more victims of this type of hypertension, especially in today's time?
First of all, thank you, Mary, for getting me here. So coming to your question, traditionally, it has been thought that pulmonary hypertension is a disease of the young. So a peculiar patient of pulmonary hypertension was supposed to be a young female who is between 30 to 60 years of age, and she comes with symptoms related to pulmonary hypertension. However, recently, a change in trend has been observed. In fact, there's a data by a US registry which has shown that approximately 17% of the patients who are diagnosed with pulmonary hypertension are more than 65 years of age. There's a multinational European registry which says up to 63% of patients diagnosed with pulmonary hypertension are more than 65 years of age. Similarly, there's a Compara trial, which was mainly done in Germany, which also says that the highest median age of patients observed diagnosed with pulmonary hypertension was 71 years. Unfortunately, we do not have a very comprehensive Indian data which related to this question, but it is expected to be in similar terms with the German data as well as the European data. The reason I believe this is happening is because the symptoms of pulmonary arterial hypertension, like we've discussed, are very vague. Mainly patients present with dyspnea, fatigue, and swelling in the legs. So it keeps on getting ignored. And by the time they get diagnosed, it's pretty late. So in general, these patients get diagnosed after 5 to 10 years after the onset of the disease, and which is very detrimental to their prognosis, because the earlier you diagnose this, the better you can treat it. So more than that, I think even children are being diagnosed with pulmonary hypertension. As Dr. Arun has discussed, it has a varied etiology, varied causes. So patients with congenital heart diseases, uncorrected, they also present with pulmonary hypertension. So in general, earlier it was thought to be a disease of young females, but like it said, pulmonary hypertension does not discriminate. It can affect people of all ethnicities, of all sexes, of all ages, including children as well as elderly population.
So that is a very interesting study that you did point out in Germany. Is it in that study too, does it specify women in the age category of 60, 65 plus?
So it's a mixed group. Around 60% of the patients were females, but 40% were males as well. So like it said, PH can happen in all ages and all sexes.
Yeah, the skew is not very large here, actually. Dr.
Right.
Nitin, could you help us understand a little more about what are the factors that can cause or contribute to PH? I know we've discussed it in a little bit of detail already, but it always bears hearing a couple of times. So If you could tell us, it would be great.
Yeah, thank you, Mary. There are numerous factors or causes which can lead to pulmonary hypertension. First of all, we have to divide into two classes, that is secondary and primary. Secondary, which we know the cause, basically is from the basically pulmonary hypertension, right-sided pathology. So secondary hypertension usually comes from the left-sided pathology, like LV dysfunction, cardiac failure. Then the most important is the primary, which we are discussing. So the primary pathology, it is the lungs are affected or the pulmonary vessels are affected, like pulmonary embolism, HIV. Now that there is drugs, methamphetamine and cocaine, which can also lead to pulmonary hypertension. The most important group is the connective tissue disorder, like rheumatoid arthritis, systemic lupus erythematosus. So these diseases are very common in females. So pulmonary hypertension or the idiopathic pulmonary hypertension is much more common in females as compared to the males. And the most important group of drugs of the disease, which my earlier colleagues have said, is the congenital heart defects, like the hole in the heart in the children's, which can lead to pulmonary hypertension, like the ASD, VSD, PDA. They can be divided into two groups like cyanotic or acyanotic. Both can cause pulmonary hypertension. So these are the numerous causes which can lead to pulmonary hypertension or the factors which can lead to pulmonary hypertension.
Thank you, Dr. Nitin. Dr. Ashish Singhal, welcome. Dr. Ashish Singhal is a DM cardiologist at Yamuna Vihar, New Delhi. Doctor, I'm directing the next question to you. Now that we've talked about, what are the causes or the contributors to PH, could you now help us understand what are the symptoms of PH?
Symptoms of pulmonary hypertension are as simple as starts with shortness.
Doctor, I think we are having a little bit of a problem hearing you very clearly.
So the symptoms of the pulmonary hypertension includes dyspnea. First, it started with shortness of breath. Patient started feeling shortness of breath even on the mild walking. And in the severe stages, patient feels dyspnea even at the rest. Second, the patient can have chest pain. Third, the patient can also develop because of the right side heart failure swelling in the legs. And in massive pulmonary embolism, there can be falling blood pressure, dizziness, and fainting. Patient can also suddenly lead to loss of consciousness. In 20 to 30% of the patients, they can also develop hemoptysis in the form of blood coming in their sputum. In massive pulmonary hypertension because of the repeated recurrent bouts of cough. These are the usual symptoms which a patient experiences when suffering from pulmonary hypertension.
Thank you, doctor. I must confess, if you don't mind, we are having a little bit of a problem hearing you. So perhaps you could try without the earphones. Maybe it might be better in the next question. We'll see. We'll take it as it comes. Yes. Thank you. Dr. Vikas, now that we have talked about symptoms, for me, my brain only processes things logically. So I wanted to know, now that we've talked about the symptoms, can we talk about how it's actually diagnosed? How is this now diagnosed?
So the gold standard of diagnosis or confirming the diagnosis of pulmonary hypertension is usually a procedure called cardiac catheterization, in which a small wire followed by a long tube, which is a millimeter or slightly bigger than that, put into the heart and pressure is measured. But to reach that point, the patient has to go through a long process whereby a suspicion is reached. So as has been mentioned, there are symptoms, but those symptoms are in the gray zone for pulmonary hypertension and are there in a large number of patients. Probably the first clue usually arises when the doctor listens to the heart, and on listening to the heart, he thinks that there is something which doesn't fall in place. And then he gets an X-ray and an ECG, and the X-ray and the ECG may give the first indication that it is not the left heart which is the problem, but also has affected the right heart now and via the lung. So the pulmonary hypertension suspicion first comes through the X-ray, ECG, obviously first with the symptoms, then by the X-ray, ECG, and finally there is a test called echocardiogram done. The echocardiogram is an ultrasound of the heart, which is a pretty standard test. And this test can actually confirm the diagnosis to a significant degree, especially if a patient is presenting slightly late. The diagnosis can be confirmed on echocardiogram, and one can be sure that this is pulmonary hypertension, which is the cause of all the problems, and probably the etiology or sequence of how and what caused the pulmonary hypertension, if there is a cause, can also be found in the heart. So echocardiogram remains the primary center area from which all diagnoses emerge in cardiology with a confirmatory note, followed by reconfirmation if needed by the clinician on a cardiac catheterization. Though the World Organization says that every single patient needs to have a cardiac catheterization, I think in our country, when patients can present a little late, we sometimes defer the use of cardiac catheterization and can confirm it on echocardiography itself. So the cornerstone of suspicion of diagnosis or confirmation of diagnosis remains to be primarily echocardiography associated with smaller tests, which include an X-ray, ECG, clinical symptoms, and a sequence of blood tests to rule out other conditions like the rheumatological conditions of rheumatoid arthritis, lupus, etc., which have also been mentioned. So the gamut of diagnosis starts from echocardiography and may extend into cardiac catheterization, which is an invasive procedure.
Doctor, I'm going to stay with you and ask you a general layman's doubt, which is, how is this different from regular hypertension? Because, probably, you just put that band around your arm and you can figure out regular hypertension. So could you help us understand the difference?
That's actually a very interesting question, a very important one. So lungs, as I said, is the only organ in the body which has a pressure of about 25 to 30 maximum. And the only way we can assess that pressure is if it starts affecting the heart, or if we go in and check the pressure with a micro tube. These are the two methods we check it. Now, otherwise, it practically can remain asymptomatic for a very long time. But before all this, hypertension, systemic hypertension, the common one that we talk about, is extremely common. 1 in 5, 1 in 7 people would be having hypertension, 1 in 10 would be having. Pulmonary hypertension or lung hypertension is there only about 15 out of a million people. It is that rare. So you're really looking at a needle in a haystack, and then you're sifting through the symptoms which are common for a large number of conditions. And then finally the doctor smells and falls on the trail of pulmonary hypertension through an X-ray or an ECG and says, hey, this is going the wrong way. We need to look at the lung because it's the right heart which is getting affected with high pressure. And then the diagnosis gets confirmed. So it's actually picking up the scent of a diagnosis through a variety of methods and then concluding it is pulmonary hypertension, which is quite often a long cycle. Many times over several months or years, a patient keeps going through tests, doesn't get confirmed, and finally comes up with a diagnosis.
Got it. I think that makes it pretty clear. And it's also pretty clear, and this is a shout out to all the patients out there, all the people listening in to us right now and following us on this webinar. Please note that the doctor you should be consulting is a cardiologist for this particular. Am I right, doctor? Is that how it works?
It can get started with an internal medicine doctor or a pediatrician who may say so. So it could be anyone in the sequence of medical care who raises the suspicion first, because the doubt can arise on an X-ray. So a radiologist may raise the suspicion, or an ECG, plain ECG. So the first person who doubts and puts down, rule out pulmonary hypertension is the person who actually is most valuable in the chain of diagnoses that subsequently happens.
Thank you. Dr. Ashutosh, let's talk about PH now. And since we have, agreed that this is something that actually takes, it's complicated diagnosis. What happens if it's not treated? What happens if it's just not detected? What are the complications we're looking at? Dr. Ashutosh, you're on mute.
Yeah. Am I audible? Yes.
Yes, thank you.
So just like any other condition, if you leave it untreated, obviously it's going to harm your body. So pulmonary hypertension, as Dr. Kohli pointed out, that the balance is 30 millimeter, upper limit of pulmonary artery pressure is like 30 millimeters of mercury. So whereas your rest of body is perfused at pressure of 120/80. So it's a very, very delicate balance that one has to look at. The pressure going up to 40 may not get detected, but suppose it goes beyond a certain limit, obviously the patient will start having symptoms. So complications will be, if it is gradual onset, maybe the patient will tolerate for a longer time. But suppose a patient develops pulmonary hypertension secondary to what we call as a thromboembolic phenomena, where the clots may migrate from the calves or any other part of the body and lodge themselves into various parts of the lungs. So this will be leading to acute pulmonary artery hypertension, acutely, because the blood vessels are blocked, so pressures have gone up acutely. So when this kind of phenomena happens, then acutely the patient will become sick, develop features of breathlessness, will go into right-sided heart failure in the form that the liver will get enlarged, the tummy will get swollen, the urine output will get decreased. So this is kind of a critically sick patient. But if you look at a chronic patient who has various other causes or uncorrected heart disease or blood dyscrasias like sickle cell or something, or an idiopathic variety where there is nothing, there is no cause, but it is, or we couldn't find a cause. So that's why we call it an idiopathic or a primary variety. So these patients will probably, they will become gradually breathless, fatigue. They will not be able to be as active. I've seen patients who say we cannot even walk for 1 minute. So we do what we call as a 6 minutes walk test. And many patients who are having severe pulmonary hypertension, they cannot even complete that 6 minutes walk test. So they also tend to have abdominal swelling because the liver gets enlarged. Many times they have some water collection in the stomach because the right heart is failing. They may have pedal edema or swelling of the feet. Very high pulmonary hypertension, they tend to have syncopal attacks. That is, they become unconscious. They fall because the heart is not able to generate or pump out enough blood into the lungs, so that there is no blood supply or oxygen supply to the tissues. And left untreated, then it can cause hemoptysis because of bleeding from the lungs. So, and untreated is obviously fatal. And if you're not treating, then most patients probably will progress to this condition is rapidly fatal. Let me say that primary untreated pulmonary hypertension is rapidly fatal. Probably most patients will not live beyond 5 to 6 years if they progress rapidly and if they are not attended to or not treated on time. So picking up symptoms and trying to find out where is the etiology. Etiology is most important. If we are able to figure out the etiology, whether it's thromboembolic phenomena, etc., we can prevent the progression. But wherever we don't have the cause, or we call it a primary, then the drugs are the mainstay.
Got it, doctor. I think that's clear enough for everybody to understand that the moment there is some kind of a symptom, a red flag has to be raised. Dr. Arun, since we are aware now that a lot of women are affected by this, and especially, starting from the age of 30 onwards, could you help us understand what's the connect with pregnancy? Can they go ahead with pregnancies if they are diagnosed, or if they are suffering from PH?
Hyperdynamic circulation, because it requires a lot of cardiac output increase, because obviously the mother needs to supply blood to the child as well. So pregnancy demands increase in cardiac output, which the patients who are already having pulmonary hypertension, in these cases it is not possible, because the lungs are weak and it puts a strain on the right ventricle, so leading to right ventricular failure and all the symptoms which Dr. Ashutosh rightly described. So if you speak about the mortality, see, the mortality is very high in women having pulmonary hypertension. If they have pregnancy, the mortality is as high as 25 to 50%. So as a doctor or as a clinician, we do advise all our patients not to continue with their pregnancy, because it is very difficult for them, because once the circulation changes happen, it is very difficult to control, and most of these patients end up having a right heart failure and eventually leading to death. But on general, in Indian population as well as across the globe, we see most of the women willing to continue the pregnancy. In those cases, there are very limited drugs which are available to us, which are safe to the child as well as the mother. But in general, as a clinician, we do advise that do not continue the pregnancy because of the high mortality and complications.
But that also brings about a very serious social complication in this whole thing, because people don't understand the seriousness probably when they...
The first sitting for any clinician for a patient with pulmonary hypertension is very difficult. You need to draw the diagram of heart, lung, explain them everything very clearly, and make them understand that what is exactly going wrong. So eventually the trust will not be built on the first visit. Once they find relief with your medication, eventually the next visits you can discuss with all these things. Upfront discussing about pregnancy in the first visit is not advisable.
And also the family has to get involved then, because
Yes.
this is a larger. Okay, thank you. It is rather serious and sad when we, think about it from that context. Dr. Harnish, of course, we believe that COVID is in our past, and at the same time, it seems to be lurking in every nook and corner as well. Um, please tell me, what is your experience? Do you feel that post-COVID, there is now an increased, frequency of pulmonary hypertension among people?
That's a very interesting question. So, pulmonary hypertension is prevalent in patients who are suffering from COVID-19 as well as patients who have recovered from COVID-19. So, as we have all witnessed in our clinical practices, I'm sure all of the panelists would also agree with me, that a lot of patients who are now coming with pulmonary hypertension have had at least moderate to severe COVID pneumonia in the past. So the etiology for this could be different in different cases. The main factor responsible is the extensive lung damage which these COVID patients have left for their lifetimes. This leads to formation of lung fibrosis over the time, which leads to increase in the resistance of the blood flow to the lungs, which ultimately leads to formation of hypertension in the arteries of the lungs. Also, the formation of lung fibrosis leads to decrease in saturation of the blood in the body. And as we know, the arteries in the lungs, they have an inherent property to constrict when the oxygen saturation falls down, which leads to further constriction of the pulmonary arteries, and which further leads to development of increase in pressure and thus PAH. The second most important factor, which is responsible for development of pulmonary hypertension in these patients, is formation of blood clots. COVID is a atherogenic disease. It leads to formation of blood clots throughout the body and also in the in the arteries of the lungs, and thus it can lead to pulmonary hypertension because of the increase in the resistance or increase in the pressure to the blood flow. So this is nothing but the type 4 PH, which we've already discussed. The lung disease leading to PH is the type 3 PH, which we've already discussed. Similarly, COVID can also lead to the disease in the left side of the heart, leading to dysfunction of the left side of the heart, and thus the pressures can be transmitted to the right side of the heart, leading to pulmonary hypertension, type 2 PH. So COVID can essentially lead to all types of PH. It's definitely more prevalent in COVID patients. And in fact, when there was peak COVID, the first and the second wave, I was working in Savai Mansingh Medical College, Jaipur, and I have published data in Indian Heart Journal where the incidence of pulmonary hypertension in COVID patients was 22%. And I'm sure there are a lot of other studies done in India for the COVID patients where the incidence varies from 15 to 25%, which is a big number. And in fact, this number could be much higher, I feel, taking into account that doing echocardiogram in these patients is slightly challenging because they're mainly sometimes they're on ventilators, and doing all the tests can be difficult in these patients. So in general, patients who have had moderate to severe COVID, they have more chances of developing PH later in life, and thus they should be screened more often than the regular population with just a screening echocardiogram, which can tell us about the pulmonary pressures. So even though the world is recovering from COVID-19, it has left us with this challenge of pulmonary hypertension.
Yet again, doctor, I confess to my little ignorance. When you say had COVID, definitely it is COVID which has affected the lungs.
Exactly.
Okay, all right. Thank you, doctor. Dr. Nitin, we hear all the time these days about lifestyle diseases and things like that. Do you think that there are any lifestyle changes that we can all implement which would help us to avoid diseases like pulmonary hypertension?
Per se, I will say pulmonary hypertension is a disease of the vessels. And because of the secondary hypertension or the primary hypertension, there are not so many lifestyle changes or dietary changes which can be help us to recover from the disease. But yes, first following, eat healthy and balanced diet. Avoidance of smoking is must. because smoking puts strain on the respiratory system. It can lead to increase in the pulmonary pressures. Staying active and exercising as per the capability, not much, not less. There is a 6-minute walk test also for diagnosing this disease. So staying active and exercising is much more helpful than maintaining healthy body weight, because obese patients are much more prone to secondary hypertension as well as the primary hypertension. And it can lead to sleep apnea also, in which the pulmonary pressure rises and the patient has difficulty in breathing. So obesity is a disease which can lead to obstructive sleep apnea, which can lead to increase in the pulmonary pressures. Avoiding traveling to the high altitude, because it can lead to strain on the lungs as well as the heart. As compared to the dietary changes, eating high fiber diet, like diet rich in fruits and vegetables with lot of potassium, magnesium and calcium are important. Avoidance of alcohol, and we have to think about the fluid intake, because in pulmonary hypertension, their fluid get accumulated in the lower middle edema, because the patient usually complains of the swelling in the lower limbs. So we have to think, restrict them and guide them about to have a limited amount of fluid to be intake. So these are the lifestyle changes and the dietary changes should be taken care of.
Thank you, Doctor. Dr. Ashish Singhal, are you there? Dr. Ashish has left us for a little bit. I think he's working on his audio, perhaps. Dr. Vikas, I'm coming back to you. How similar is the ailment? How similarly does it manifest in a multitude of patients? Is it the same kind of symptoms and everything?
So this is a very important question. And I'll go back to the question you had raised when we were just starting. Is it PH or PAH?
Yes.
That was a point you were raising, and we kind of skipped through that. So PH is the generic disease, and PAH is just one of the causes or one of the types of the PH which is there. There can be other causes, and that brings us to what are the symptoms and what are the varieties of PH a patient may manifest with. So, it depends on what caused it. If it's primary, which means there is no cause, it's unknown etiology, why it happened, probably genetic, or maybe without even genetic causes, then the manifestation is going to be the way Dr. Ashutosh had described. And the manifestation is usually late in those cases, or very, very subtle symptoms of shortness of breath, inability to perform to the same level in terms of climbing stairs, walking, may start manifesting, and the patient may just compensate for it for months or years before he gets to know that it's happened. But on the other hand, there were certain other categories mentioned, for example, thromboembolic type of PH, which is secondary to, say, a patient had surgery and he had a fracture, and that surgery was done, but was not given any medicine to avoid clots while he was on bed. And those clots migrated from his leg and went into his heart and into the lungs, and they blocked majority of his lung arteries. So that is another cause. So that may manifest in a totally different way. A person who had a fracture undergoes surgeries on bed for a few weeks, gets up and he finds he's unable to breathe, and people say, oh, it's just your weakness of legs or muscles because you were lying on bed. Third group would be something like, let's say if a patient is having lupus or scleroderma, typically is a condition which causes a connective tissue disorder. So they have a different set of symptoms already. They're dealing largely with skin symptoms. And since the disease is so prolonged, and the doctors know that at some stage we need to start monitoring the heart and lungs. There, it is very early pickup of pulmonary hypertension happens, because yearly they are sent for their annual pulmonary function tests and annual heart checkups. And then it gets picked up. Okay, last year the pressure was 35. This year it is 42. And then next year it is 55. We know very, very gradually it's happening. So that is how, in a variety of spectrum of manifestations can happen for a condition which ultimately results in the same thing, that the right heart gets affected, because the primary problem is in the lungs. The lungs affect the heart, and the symptoms because of back pressure from heart causing all the symptoms which doctors had described earlier.
Thank you, Doctor. But I also want to ask you, since we are still talking about an age group that is productive, active, working, etc., how does it work with the people who are suffering from PH when it comes to travel? altitude is one thing that we already touched
Yes.
upon, but every other aspect of travel, how does it work?
So it does affect their capacity to work. I think we need more empathy towards the employers need more empathy towards illnesses of our patients who are listening to all this, that if they are unwell, if there is somebody having an influenza or cough, cold, and they want to isolate themselves in office workspace, all that needs to come into place. It's affecting all our patients all the time on a daily basis. But your specific question is to travel. So air travel, short distance air travel. Now airplanes are pressurized. They're not pressurized to the same degree as sea level, slightly less than that. So short distance domestic air travel is not a challenge, except for the very, very late patients. But international air travel becomes a challenge. And I've had 2 or 3 patients who are very, very late into the manifestations, and with all due precautions of fluid intake, of taking their medicines with change of time zones, and of carrying oxygen, informing the airline, etc., etc. We've been able to allow these patients to, with a very high hemoglobin and very low oxygen level in the range of about 70, 75, we've taken the chance of having them travel via air to different places internationally also. So yes, there are certain guidelines which are available. Patient needs to know, airline needs to know. It cannot be hidden from either of them, and they cannot just decide to undertake. Now, when it comes to altitude, with due effect of what has been already mentioned, I'd like to say that they can go to lower heights, like 5,000, 7,000 feet. They can go to. For example, they can go to Shimla, they can go to Mussoorie. These are normal places. Manali, they can go to. But beyond Manali, and specifically Leh Ladakh, they cannot go to. So very specific levels which are again defined, which we can tell our individual patients that above this level, you cannot go and you should not go. So for example, they can go to Sikkim, but not to North Sikkim, which is at a much higher altitude. So let them also enjoy life with certain lines drawn towards how much and where they can go. I hope that answers your question.
Yes, absolutely. Very important for everybody to know, because everybody's striving for normalcy, especially in what they call the revenge tourism. Everyone's
Right.
trying to go out and get the best of what COVID, took away from them. Dr. Ashutosh, at what stage do PH patients get hospitalized? Doctor, are you on mute? Yes, you're muted, doctor.
Yeah. So this is an important question, that when do they hospitalize? So I guess if a patient who is acutely sick is having symptoms such as severe right heart failure, that's syncope or severe breathlessness, pedal edema, that would be one indication to hospitalize that patient. Put this patient on some oxygen, try and decongest his lungs, liver, and make the therapy. And second would be a freshly diagnosed case. Why would you want to admit freshly diagnosed cases? You want to probably evaluate. So these patients would be admitted for various tests. Many times we go in for a CT angios to rule out certain malformations in the liver. And maybe sometimes we need to look at if there is any pulmonary embolism. We may want to do what we call is a challenge test with medicines to see if the pulmonary artery pressures drop in response to certain group of medicines. And if that happens, then these patients are called reactive or reactors. So they can be given additional calcium channel blockers. Then anytime a patient with pulmonary hypertension has hemoptysis or has a respiratory tract infection, these patients can worsen. So they may require hospitalization to tide over that particular crisis.
And what are the suggestions that you have for hospitalized patients? Is there anything that you would suggest that they, do particularly, or for bystanders? Is there anything extra special that needs to be taken care of?
So if you have a patient who is diagnosed case of pulmonary hypertension, and it doesn't say that pulmonary artery hypertension patient cannot have any other illness. He could be hospitalized because of any other illness, say a gallbladder surgery or a fever or anything else. So and majority of times the complications to pulmonary artery hypertension happen during unrelated surgeries or unrelated treatments. So the doctors have to be aware, rather more than important than patient has to be aware that I have this condition. So that is one. And then it all starts with that, they have to be given little more comforting kind of treatment, acute pains, sudden change in fluid balance, giving a lot of fluids or not giving fluids or dehydration. All this could make a difference to that patient. So pain management, anesthesia management, ICU care to maintain adequate fluid intake and output. So all that makes a difference to these patients for if they are going for treatment for some unrelated conditions.
Absolutely. So it helps both the medical professionals looking after them as well as the, the bystanders. Thank you so much, Doctor. Dr. Arun, I'm coming back to you now. Now let's talk about the treatment options for PH. And of course, I want to dwell on a particular aspect, which is the relation between PH and sleep apnea as well.
Sleep apnea, as we already discussed, like PH is hugely underdiagnosed. There is a lot of social stigma attached to it. Though people are obese, it is not that all obese patients have obstructive sleep apnea. It is not that lean patient doesn't have obstructive sleep apnea. It is all your symptoms you need to screen. And many times when you ask the patient about snoring, and they tend to avoid the question. So it is imperative on the doctor that once you are suspecting PH, you should rule out all the possible causes, which includes obstructive sleep apnea. One is one of the major contributor to this disease. Now, as we all know, obstructive sleep apnea is a lifestyle disease. This correlates with your earlier question, whether lifestyle changes can improve your PH. Yes, this is one aspect where lifestyle changes do improve pulmonary artery hypertension. For example, once you start your patient on treatment, the patient uses CPAP or BiPAP regularly, which is the gold standard treatment for obstructive sleep apnea. And he also maintains a positive lifestyle where he tends to lose the weight. You can see the pulmonary arterial hypertension going down. And the second thing regarding the treatment options, it depends upon the group of disease, because once you identify the patient is suffering from this particular disease, you tend to place the patient in the group which is given as per the classification. What is the root cause or the etiology? So the treatment options are available for particular groups. For example, regarding my specialty, the group 3, the treatment options are very limited. You tend to treat the primary disease. In case of asthma and COPD, you treat the primary disease. Whereas in obstructive sleep apnea, I told you, we'll treat with CPAP or BiPAP. That is the primary treatment. Whereas specific therapies for PH are more targeted towards group 1 and group 2. And cardiologists do start them on therapy depending upon the grade of the pulmonary hypertension. And eventually the patient symptomatic improvement is the more essential thing. Patient always comes back to you and tell you that whether there is a symptomatic improvement or not. Accordingly, you can add combination therapy or add a new drug. That's how it goes.
Thank you, Doctor. Dr. Harnish, could you tell us, since we did touch upon the treatment, perhaps you could help us understand a little more about treatment, and while we talk about treatment, could you also help us understand a little more about supportive therapies, if there are any, for PH?
All right. So coming to the treatment part, as Dr. Arun has already discussed, it's mainly focused on what type of PH it is. So when it is type 3 PH, which is related to the lung diseases, it is mainly the pulmonary physician who takes care of it with all the treatment options which he has already discussed, like a BiPAP or a CPAP therapy, which could be given at home. Home oxygen therapy is another thing. When it is related to other types of PH, like suppose if it's a type 2 PH, which is because of the left heart disease, it is the left heart disease which you have to take care of. Sometimes there are valvular lesions. The valves of the left heart could be problematic. They could have some degree of obstruction in the form of stenosis or leakage in the form of regurgitation. So you have to take care of that. If it is the left lower chamber of the heart, left ventricle, which is dysfunctional, you have to identify the cause for it, which could either be a coronary artery disease or some inflammation of it, and you have to take care of that. So that is another option. If it's a hereditary or idiopathic, the cause of which is unknown type of PAH, then mostly the therapy is based on the specific therapy of PAH, which includes medications. There are multiple groups of it, and we usually put the patient on combination therapy. Apart from this, a lot of these patients, since PAH is a chronic, progressive, life-threatening disease, patients live with this disease for a really, really long amount of time. And they have a lot of functional limitations in the form of not being able to do routine activities, more than routine activities. Like we've discussed, it's difficult for them to go to high altitudes. It's difficult for them, if it's a young female, it's difficult for her to get pregnant. It's difficult for them to even get exposed to areas where they're prone to get infections, because they're very prone to develop respiratory tract infections. So they require a lot of supportive therapies. They require a lot of even psychological support for that matter. So in supportive therapies, what we usually give to all of these patients, which are not specific to any particular group of PAH, is mainly diuretics. Diuretics are the medicines which lead to increase in the urine output of the patient, which leads to more pouring of urine. That leads to some reduction in the pulmonary artery pressures of the arteries of the lung. Second is long-term oxygen therapy. Like we've discussed, if the blood oxygen levels are reduced, they're prone to develop even more pressures in the arteries of the lung. So a long-term oxygen therapy is advised to almost all group of PH patients. Third is they're more prone to, as we've discussed, blood clots in the arteries of the lungs are cause as well as consequence of pulmonary arterial hypertension. So they can even develop clots because of PAH. So usually these patients are given some sort of blood thinners as well in the form of anticoagulation. However, it's a double-edged sword because they can also have hemoptysis. So you have to actually balance it out in majority of these patients, and a personalized approach is required for each patient. These patients, if they have some sort of iron deficiency, they can have reduced hemoglobin, and already they are having less oxygen in the blood. So even reduced hemoglobin can lead to further deterioration in the functional capacity. So if that sort of things are present, you have to correct those. Apart from this, like we've said, if the patient has severe PH, pregnancy is to be absolutely avoided. In mild to moderate PH, pregnancy can still be taken under supervision of a cardiologist and a gynecologist with proper guidelines. These patients are more prone to develop infections of the respiratory tract. So they should be vaccinated for influenza as well as pneumococcus. Ideally, every year, every seasonal vaccination should be given. They also tend to suffer from some sort of depression or anxiety. So a lot of psychological support with the help of a psychiatrist or a clinical psychologist should also be provided. Even though they have exercise limitation, what I feel is they should be encouraged to perform some sort of routine exercises, but it should be supervised by an occupational therapist. And obviously high altitudes are to be avoided. In terms of surgery, as we've already discussed, whenever they get admitted for any other routine surgeries or anything, a very, very personalized, specialized approach needs to be taken in terms of their volume status, in terms of anesthesia. Usually it's preferred for as much as possible to avoid general anesthesia and go with local anesthesia. So these are the entire aspects of how a particular patient with PH should be counseled, should be treated, should be managed.
Thank you, Doctor. Dr. Nitin, I'm coming to you with a very critical question as far as I'm concerned. We've discussed all these symptoms, the treatments, the supportive therapies. Firstly, is this reversible or curable? Dr. Nitin, you're on mute, please.
Now I'm audible?
Yes.
Yeah, Marriage, it's a very important question, an interesting question also, because PH is definitely treatable. But if you are asking curable, it is a slightly dilemma, because we want two things: symptom control and progression of the disease. We have to control the symptoms also and to delay the progression of the disease. So we have many drugs, as my earlier panelists have talked about this. We have diuretic and oxygen therapy are the two mainstay of therapies, because diuretic to relieve the congestion and to make the urine more, so the swelling does not occur and swelling breathlessness relieves. While the oxygen therapy, because these patients have a we have to maintain their saturation not 97, 98%, but 92, 90% are sufficient for them. So sometimes the domiciliary oxygen, patient usually take oxygen at the home while traveling with their oxygen cylinders like oxygen concentrator traveling with them. So we have many drugs like phosphodiesterase inhibitors, endothelin receptor antagonists, which helps to control the symptoms as well as slow the progression of the disease to make them live longer and feel better. The two main criteria: patient should live better and should have a free of symptoms and progression of the disease. So definitely we have some medicines and some procedures also which can control the symptoms and delay the progression of the disease.
So you're saying that the symptoms can only be controlled,
Yeah,
but it can't be cured.
yeah, exactly.
Okay. And of course, by control, you also mean that lifespan can be extended.
Absolutely, because in every disease, deadly disease of cardiac or respiratory problem, we want the patient should live longer and without the symptoms. Similar in the heart failure, we have so good medicines which can delay the progression of the disease and patient feel better. So if the patient is living better without the symptoms and with the help of these medications or procedures, we are happy with that. But to reduce the pulmonary pressures, to reduce the strain, it demands so much of things. So I think that these definitely treatment should be given to the patient to prevent the progression of the disease.
Thank you, Dr. Nitin. Dr. Ashish, my question to you, I hope your system is working slightly better, but we're good. Let's take this risk and run with it. Dr. Harnish did touch upon vaccinations. Could you tell us a little more about the role of vaccinations in management of PH and also the effect of exercise?
So, as Dr. Hanish has told, the role of vaccination is in preventing a deadly lung infection. Whether it's an influenza vaccine or a pneumococcal vaccine, it prevents the extension of the infection to the widespread into the lungs. And thus, those patients who have already diagnosed with pulmonary hypertension, their lungs are weak, they are already oxygen deprived. And once the lung infection sets in, they are runs into multiple complications, and there are more chances of getting into respiratory failure and cardiac arrest. So if the person is vaccinated, the chance of containing that infection or to a milder form is quite good. As this is the case we observe even in the COVID times. Once the patient who is vaccinated for the COVID, they develop infection, they restrict it to the milder form or milder form of severity. Secondly, the role of exercise is quite important in every disease, particularly the pulmonary hypertension as well as the cardiac diseases. If a person who is started a rehabilitation program starts exercising in a gradual fashion, increases its exercise capacity, it not only improves the functional capacity of an individual, the person is ready to walk. We usually measure in terms of 6-minute walk distance. Right from the day one, a patient is activity is measured in how much he or she can walk for a distance in a 6-minute time. So if after the onset, starting the treatment or starting the cardiac rehabilitation program or exercise program, over the time we can observe the distance a person can travel is increasing in a gradual fashion. This improves the functional capacity of an individual. Also, the lungs and the heart is trained for more and more effort what a person can tolerate. So both the things, the vaccination prevents the deadly infection in a severe form, and second, the exercise improves the functional capacity of an individual.
Thank you, Dr. Ashish. And yes, you were loud and clear. Thank you very much. Dr. Vikas, I'm going to do a quick round with all of you, where I'd like all of you to give us one sentence, a couple of sentences, just, maybe just to call out, maybe some hope, something positive that we can leave all our followers with, because this is like a door that doesn't seem to have, a room that doesn't seem to have a door. Could you help us just add a little bit of hope to this?
I'd like to tell all my patients and all other patients that there is tremendous amount of research going on in this area. And there is a lot of hope in the future with newer modalities of treatment, not just medicines and drugs, that one day, hopefully, we will reach a point during our lifetime where this disease can be reversed. That is the hope and research that is being worked on right now.
Absolutely fabulous. Thank you, Doctor. Dr. Ashutosh, how about you? Something that you would like to send out as a positive message to your patients and the followers of this particular webinar? Dr. Ashutosh, you're on mute, please.
Two things I would like to say. One, take your medicines regularly, because yo-yo medicines or irregular medicines causes marked swings in the pulmonary artery pressures. That is something we do not want. Second is, yes, the newer medicines are there, the treatments are available. Even if we are not able to reverse the disease per se as of now, we can provide them with a better lifestyle, we can make them better, and we can prolong their life. And I'm sure with the ongoing research, just as we have multiple medicines available to control systemic blood pressure, or what we call hypertension or blood pressure, I'm sure we're going to have disease treatments for this condition as well.
Thank you, Doctor. Dr. Arun.
Yes, as rightly mentioned, there are multiple treatment options. Earlier, we were not familiar with transplant option as well. These days, heart and lung transplant is also a reality. The success rate of the transplants are increasing along with the medications. One thing I would like to add is, since pulmonary hypertension is a chronic disease, do trust your doctor, believe him, he will provide the maximum relief which he can afford to you. And along with that, please continue to use your oxygen. That oxygen is not a minute or an hour thing. It is required for the entire day. So most of these patients, what they do is they take oxygen for an hour or so, and they feel that it is required, it is sufficient for the entire day. That is not the scenario. Please follow your doctor's advice, and it is definitely controllable.
Thank you, Dr. Arun. Dr. Harnish?
First of all, I would like to thank Times of India for bringing us all together and organizing such webinars for increasing the awareness about pulmonary hypertension in the patient population, which goes a long way in the treatment. Secondly, I would like to convey to my patients that pulmonary hypertension, a diagnosis of pulmonary hypertension, is not a death sentence. There are so many treatment options available. A lot of research has happened and a lot of research is still going on. So all you need to do is keep your hopes alive, from a simple medicine to oxygen therapy to BiPAP, CPAP, to even heart and lung transplant. All the options are available. We just need to discuss it more often, be more hopeful, and take your treatment as advised by a physician. Thank you so much.
Thank you, Doctor. Dr. Nitin?
I think hope and optimism are the two powerful words in which we are living. So these two words should be kept in mind. And by the awareness the Times of India is doing now these days, it's really helpful for the patients. So we must be hopeful, as all the speakers earlier said, as per the research is going on, this tremendous research is going on. So we are not so far, then we get some good molecule which can reverse the disease. So best of luck to all of us.
Thank you, Dr. Nitin. And Dr. Ashish?
We have all discussed everything, but the first thing is foremost the diagnosis. So even if you are having a shortness of breath, you go to a specialist, get yourself diagnosed, and if you are diagnosed in the early stage of pulmonary hypertension, mind it can be cured in certain cases. In mild to moderate first to second stages, you can come back and it can be cured completely, especially if you are having a left ventricular valvular involvement, which with a simple operation like mitral valvotomy can come down, your pressure come down normal, and you can be free of pulmonary hypertension lifelong. So get yourself diagnosed, follow your doctor's advice, and take your treatment regularly.
Thank you, doctors. Thank you very much indeed. On behalf of Times of India and MSN Laboratories, I would like to extend a very respectful and grateful acknowledgement of the amazing experience that you have shared with us today. Truly, early diagnosis, regular medication, a very positive attitude, and faith in this ever dynamic medical fraternity that is doing so much to ensure that life becomes easier and better and quality of life remains untouched. Thank you, doctors, for sharing all your experience with us. And to all our followers out there, remember, this is just a diagnosis of a disease. It's not a death sentence. So with hope, with positivity, with optimism, and definitely with the right doctors giving you the right advice about the right medication, you will all have a great life ahead. God bless you. Have a good evening, and let the world be a better place for more awareness about pulmonary hypertension. Thank you, doctors.
Thank you.
Thank you so much.
Thank you.
Thank you.
अब जा रहे